Howdy everybody, welcome back to MSK. My name is Jonathan and today we are continuing our adventure of the brachial plexus and we will be talking about the pathology Erb palsy. Let's hop into it. The pathophysiology of Erb palsy will be injury to the upper trunk, which is traditionally C5 and C6. For the purposes of step 1, you can consider Erb palsy to be pretty strictly to the C5, C6 upper trunk. Just know that in the real world, this can include other nerve roots like C7 or even C3, C4. Okay, let's take a look at our brachial plexus roadmap and see how an upper trunk injury affects the downstream nerves. So let's say that we have our injury right here on the upper trunk. Following our roadmap here, we can see that the suprascapular nerve would be heavily affected, as is our axillary nerve if we follow this posterior division, the posterior cord. The axillary nerve shares its roots, C5 and C6, with the upper trunk. And if we go down our lateral cord, we will see that the musculocutaneous nerve is also heavily affected by Erb palsy. Additionally, as it shares the posterior cord with the axillary nerve, the radial nerve will also be affected. And you may be thinking, now wait a minute, there's all kinds of nerves that are innervated by C5, C6. Why aren't those all messed up? And you're right, there are nerves like the median nerve that do receive some innervation from C5, C6. But the contribution of each nerve root to the final nerve is not uniform. So classically, we don't consider Erb palsy to also affect the median nerve or the lower subscapular nerve. Predominantly, we think musculocutaneous, axillary, suprascapular, and the radial. So to reiterate, the primary affected nerves will be the musculocutaneous, axillary, radial, and suprascapular. All right, let's move on and talk causes. How do we get Erb's palsy? The answer to that question will depend on the age of our patient. In infants, it's typically going to be a birth injury from excessive lateral flexion of the neck. So a traumatic pulling of the head away from the affected shoulder can stretch the nerve and cause damage. So this can happen when there is excessive lateral traction in an otherwise normal delivery. Erb palsy can also be a complication from an obstetric emergency known as shoulder dystocia. This happens after a baby's head is delivered. The shoulder can be caught behind the pubic symphysis of the mother. Some of the maneuvers used to get that infant out of the mother may lead to that lateral traction that causes Erb palsy. If there's adult onset Erb palsy, this will typically be from a traumatic injury. If a patient were to fall on their head and shoulder from a motor vehicle accident, maybe they were riding a motorcycle or maybe they weren't wearing their seatbelt, wear your seatbelts kids, and then falling on their head causes lateral traction, pulling their head away from the affected shoulder. Additionally, there can be damage or compression to the upper trunk from a dislocation of the humerus or a fracture at the humerus or clavicle. This might be more typical for a sports injury or falling off a trampoline while playing dodgeball at a trampoline park, something like that. And remember that location of the fracture on the arm will be a relevant clue in trying to figure out what kind of pathology you're talking about. For the case of Erb palsy, the fracture would need to be pretty high up on the arm. Something like a mid-shaft fracture would be more classical for a radial nerve injury. All right, let's move on and talk about the very important presentation of Erb palsy. What does it look like when a patient has this condition? So I think it's really important to understand how motor nerve damage leads to the presentation. So understand that at all times, the muscles in your body are all a little bit active. And so even while you're at rest, at all times, there's a balance between almost every joint in the body and its actions, a balance between flexion and extension, a balance between abduction and adduction. And so when there's motor nerve damage and we lose one side of that balance, and the patient will present with the non-impaired action of that balance. Let's use an example. In Erb palsy, the patients will have AD adduction of the arm. So the arm will be held close to the body. This is because there will be impaired AB abduction by the deltoid, which is innervated by the axillary nerve. So normally there's a balance between abduction and adduction at the shoulder. But when motor nerve damage impairs the deltoid, only adduction is left, and so the patient will have their arm adducted to their torso. Additionally, patients will present with flexion of the wrist. This is because the extension by the posterior forearm is impaired from the radial nerve, and so the flexion of the wrist predominates. There will be pronation of the forearm and extension of the elbow, because the biceps brachii from the musculocutaneous nerve will be impaired. And finally, there will be medial or internal rotation of the arm from the infraspinatus and supraspinatus by the suprascapular nerve. But as long as you know that these are the affective nerves, you can deduce what the presentation would look like in a patient. If I know the musculocutaneous nerve is affected, then I know that the biceps brachii will be affected. And I know that supination and flexion of the elbow are going to be gone or reduced. And so the patient will present with the opposite of that. They will have forearm extension and pronation. So if we can understand the nerve anatomy, then the presentation makes sense. In infants, there will also be a reduced Moro reflex. Based off of the motor deficits that we've talked about, can you guess what are the possible motions that might be, even if you haven't heard of the Moro reflex? So the Moro reflex, or sometimes called the startle reflex, is when you make a loud noise, or if you gaslight the baby into thinking you're about to drop it by suddenly lowering its head, it will abduct and extend its arms up, similar to the way you're going down a roller coaster. But as we already discussed, abduction by the deltoid is impaired in a patient with Erb palsy. And so in an infant with Erb palsy, the affected side won't have that arm abduct up with the Moro reflex. And lastly, we'll see a reduced sensation in the C5, C6 dermatomes, which will be this anterior area of the forearm, arm, and thumb. Which brings us to our mnemonic. Erb gets dibs on tips. So in this mnemonic, Erb, our very selfish waiter, representative for Erb palsy, will get dibs, an acronym for our affected muscles, D for the deltoid, I for the infraspinatus, B for the biceps brachii, and S for the supraspinatus, on tips, because Erb palsy presentation is often referred to as waiter's tip. And lastly, let's go over treatment of this condition. Because Erb palsy will leave the patient with medial internal rotation of the arm and extension at the elbow, we're going to immobilize it in the opposite position, with flexion at the elbow and external rotation of the arm. Immobilizing in this position will help reduce the stiffness in the active muscles and strengthen the weakened muscles. Physical therapy will also be very important for strengthening weakened muscles, especially for infants, and if very severe, surgery may be necessary. All right, let's do a recap and then we'll do a practice question together. Erb palsy will affect the upper trunk, which is classically C5 and C6, and will affect the musculocutaneous, axillary radial, and suprascapular nerves. The cause of Erb palsy will be dependent on the age of the affected patient. If the patient is an infant, it's most likely from excessive lateral traction during delivery. If the patient is an adult, it's more likely a traumatic incident from a motor vehicle accident, a fall, dislocation, or fracture. The presentation of Erb palsy often gets referred to as waiter's tip sign, with adduction of the arm, flexion of the wrist, pronation of the forearm, extension of the elbow, and medial rotation of the arm, with reduced Moro reflex in infants because that motion involves abduction of the arm, and loss of sensation in the C5, C6 dermatomes. Treatment is about strengthening the weakened muscles and reducing stiffness in the active ones with immobilization, physical therapy, or if very severe damage to the nerve has happened, surgery may be necessary. A practice question might sound something like this. A G2P2 woman gives birth to a boy at 42 weeks gestational age via vaginal delivery. The birthing process was complicated by shoulder dystocia, which eventually required a forceps delivery. The child's APGAR scores were 7 and 9 at 1 and 5 minutes respectively, and the child's birth weight is 9 pounds 6 ounces with vital signs within normal limits. On physical exam, you notice elbow extension and forearm pronation, in addition to a reduced Moro reflex. What additional motor deficits are also likely to be found in the patient's affected arm? All right, in this patient, there was the reduced Moro reflex in addition to adduction of the arm and pronation of the forearm and extension at the elbow. So the question of what additional motor deficits are most likely would be flexion of the wrist or medial internal rotation of the arm. All right, guys, that's everything from me today. Thanks for watching. Good luck studying, and I'll see you next time.